had a really wonderful weekend. It was so beautiful out, and I feel like this spring in Michigan, that's not a thing you can reliably depend on. So take advantage of it while we have it. We're so thrilled to have Analisa Packham here today to share with us her work on contraceptive choice. Analisa is somebody that I really enjoy in the field. She does work on a range of topics: labor, health, criminal justice, and kind of approaches it in kind of a similar way that I do in a lot of my work, thinking about like whether or not our government programs are achieving their intended aims, maybe what some of the unintended consequences are, and particularly how these impact vulnerable populations. And so that said, I'm going to turn over to Analisa. She's going to take questions as we go, so we'll go for 50 minutes. Jump in with your questions. She's an economist, and so she's expecting you to interrupt. Otherwise, it leaves us all feeling uncomfortable and insecure. So, take it away.
Okay, thanks so much. And thank you all so much for having me. It's been a really enjoyable morning so far, and I'm very excited to have a chance to talk with more of you. So for those of you guys who I haven't had a chance to meet yet, my name is Analisa. This project is joined with a graduate student at Vanderbilt University, Jessica Kaiser, who does a lot of work on maternal and infant health and will be on the job market in the following year. And Jessica and I have partnered with 3 individuals, Janelle, Eve, and Emily. Janelle is a nurse that works in the clinics that we're going to be talking about today. Emily is the director of the Office of Family Health Services and in the Virginia Department of Health, and Eve is in charge of making the data widgets and collecting all the data from this program that they ran, the Virginia Contraceptive Access Initiative. So I just want to highlight here that this project would not have been possible without their support and help, especially with the data so far. So I'm excited to present this mostly because it's very new work, and we are very excited to get feedback on this because it's not under submission. We're really looking for your comments on not only like how do you feel about the results, how do you feel about the pitch, or if there's anything else that you think we might be able to look at that we haven't thought to do already. And I want to start this talk by really highlighting the policy landscape surrounding contraception policies. Just in the last year alone, there have been over 3,000 provisions at the state and local level in terms of both expanding and restricting access to contraception and abortion. And of course, now we're in this one-stop landscape where we're worried about how can we get policies that are going to be effective for women in terms of both expanding and restricting access to services. So if you think like, yeah, Analisa, okay, whatever, like this is 3,000 provisions, it doesn't necessarily mean they were enacted, and aren't these all just related to abortion? And I'll say that actually no, about 500 of these have been enacted. This is again just in the last year alone. And of these, there have been many policies actually to expand contraceptive services. And so if you're thinking like, yeah, do we really need another paper about contraception and expanding services through clinics? This is something that state and local governments are still talking about and still trying to figure out ways where we can effectively target low-income women and provide these services. We can see here that over 300 of these provisions have been passed to expand contraceptive services alone. And so I think this is really policy relevant and something that we should care about, especially as economists and social science researchers, about if we're doing this in a way that makes sense. And so in this paper, what we're going to be thinking about is how much can expanding access to contraceptives, and specifically at publicly funded clinics, how does that affect contraceptive take-up and reduce unintended childbearing? And so we're going to be looking at this in the context of this program that Virginia ran just in 2018, so a relatively recent program. And this is going to be the largest recent state-run program using public funds to provide low-income women with free contraceptives. And importantly, they have this emphasis on long-acting reversible contraceptives, which we'll talk a lot about. So things like IUDs and implants are highly effective, but also costly for women to put this on their own. And so we're going to use administrative visit level data. This is why we needed the Department of Health team to help us with this on contraceptive take-up at these clinics that are going to be expanding services beyond Title X clinics. So this is your area of research. You know what I'm talking about there. So we're going to map that to natality data. We have that both at the zip code and at the county level in the state of Virginia and nationwide. And we're going to do, our main approach here is going to be a differences approach. We're going to be comparing counties in Virginia that had these services provided. So through the Contraceptive Access Initiative, what clinics started providing these services, so contraceptives and LARCs, And we're going to compare them with birth rates in counties outside of Virginia that also have publicly funded clinics but are in the bordering states. And so we want to be thinking about, how did counties that operated these new services compare in terms of women's outcomes to counties outside of Virginia? And if you're thinking to yourself, like, okay, well, what are we going to find? Well, if you provide people with free contraceptives, they're going to take them, right? So we do see that. We see the total number of LARC insertions increases, so people get these services when they're provided to them. And we find about a 2% reduction in the birth rates in these participating counties relative to counties outside. Now, if you think, okay, well, that means that clearly this program worked. It did its job. It reduced some of the childbearing. But what I'm going to spend a lot of time talking about today is this effect is actually less than half of what other similar state-level programs like those in Colorado and those in Delaware have found in running a similar program, but earlier in a different policy landscape. And so I'm going to be focusing today on, is this effect a lot? How do we think about the cost of these programs? Where does this leave us going forward if we're thinking about telling other states that maybe they should or shouldn't roll out similar programs? Importantly, here in Virginia, we actually find zero effect on teenagers. It's also going to be different than what other programs have found before, and we don't see any effects on things like low birth weight or other infant health outcomes. I'll mention here too that as compared to, say, the Colorado program, the cost per birth avoided of the Virginia Contraceptive Access Initiative is about 3 times higher than the percent. So again, if you're thinking about this, the title of the paper, and you're coming, you're like, oh, sorry, I didn't see your hand. Yes.
Around what numbers other stable use, because we're doing that teenage birth,
yes. That's a fantastic question, which I'm going to talk about right now. Okay, yes, great question. So I promise I didn't pay him to cue me up. So there have been other programs that have been run prior to the Virginia Contraceptive Access Initiative. The famous one that I'm going to be spending a lot of time comparing this program to is the Colorado Family Planning Initiative. So this is a program run in 2009, and it is actually privately funded by Warren Buffett's foundation. So you're absolutely right. This is going to be in a different policy setting where Medicaid expansion hasn't happened yet, where Obama's contraception mandates haven't happened yet. And so when we're comparing this Virginia program to these earlier programs, we're going to be thinking this is a time when LARCs are particularly not used. This is a time when many people don't have coverage to cover those methods, either privately or through Medicaid. And so that's actually a really key point here that's going to make this paper stand out. Any other questions so far? Awesome. So what have we learned from these other initiatives, and why does it make sense to go back to the drawing board and study kind of a similar question in a new setting? Well, what we've generally found from especially the Colorado program is that providing LARCs for free, these IUDs and implants for free at a publicly funded clinic, increases take-up. And in particular, that was really a key part in reducing teen birth rates in Colorado between 2009 and 2015. So I have 2 papers on this, one showing that just in general, teen birth rates fell by over 5% when Colorado started this program in 2009, but that this also reduced low birth weight birth. So it shifted the composition of birth on top of that, and it also reduced births for older women as well. But the key finding from this 2020 paper is actually that the biggest effects were for women living very close to the clinic. So distance does seem to matter here. And why that's key is because in our setting, we're going to be thinking about not just expanding services of existing clinics, but also operating new clinics as well, which will give more women a chance to travel to clinics closer to their home. I'll also mention that there's a paper by James Flynn that's forthcoming at JCOB that kind of shows similar effects as what's been found for Colorado, but the working paper also showed that these other initiatives really that just are more information focused or just provided contraception, say only at abortion clinics, were just not as effective. So it's the money. It is offering this to women that would not have otherwise bought these devices. And that's going to be a key part when we're thinking about rolling it out today when more women just have coverage and have those devices already at a low cost. So if you're thinking like, okay, Analisa, yeah, you're doing a new setting, that's great, it's, more recent, yay. What does that mean? What are we gonna learn from this? I think one of the biggest advantages of this study is because we're able to get this really granular data at the CAI clinics that are opening up in Virginia during this time, we can really look at a wide range of contraception take-up at these particular clinics, but also that we're able to get data from Title X clinics as well. Title X, for those that aren't familiar, are just a publicly funded contraception clinics that are nationwide. And again, I really want to highlight here that I think the thing that, at least when I started this project, I didn't expect to learn is how these estimates really fit into this current policy environment in terms of like when all these other things are passed in the recent years that we've been tracking things like contraception mandates and Medicaid expansion. What does that mean for women in today's policy environment? And that's what I really want to kind of harp on a lot today and convince you that things are different now than where they were just 15 years ago when states were considering what kinds of provisions to enact. Are we okay so far? Great. So I think this also fits into a really nice bigger literature that folks here have contributed to, but also just in general, we know things like legal access to birth control pills, legal access to abortion affects birth rates, and we know that having a physical location, access to a clinic nearby is also really critical for affecting women's contraceptive choices. And importantly, because this was a LARC-focused program, I want to emphasize here that encouraging women to switch to more highly effective devices is a successful way in reducing unintended pregnancy. All of that is going to say, as economists or as social science researchers, we should really care about these kinds of programs simply because by giving women the choices to have fewer unintended pregnancies, we're giving them the power to participate in the labor force and just make more helpful economic decisions for their future. So in general, these types of programs are going to improve total social welfare by just allowing women to make better choices. The question that I want to flip on its head today is ask, can we do that in a very cost-effective way as well? Okay, so let me tell you a little bit about Virginia's Contraception Access Initiative. If I say CAI, I know I already have this talk. This is what I'm talking about. This is a program that they ran in 2018. Importantly, any clinic or any facility that felt like they could provide contraceptives, but only they had the money to do so, could apply, and all of the applicants received funding. So it was 41 clinics run by 18 health providers. And this was initially intended only to provide funding for LARC insertions and removals, but then was expanded for offering all different types of contraceptives as well as screenings. And the types of health providers actually vary quite widely. So not just kind of Title X clinics, but also federally qualified health centers, FQHCs, but also Planned Parenthood affiliates as well. So many clinics that were already kind of in existence, but just either needed more funding so they could see more people because of excess demand, or simply were not able to provide LARCs for free because of the high sticker cost. Those were the types of places that applied for this. And it's important to note that in our conversations with the Virginia Department of Health, that most of these clinics that were applying for funding, they just simply couldn't offer LARCs before, or couldn't offer even birth control pills, because for folks with no insurance coverage, because they just didn't have the funding. So they might have, for example, been a facility that was offering breast exams or STI screenings, but they just couldn't offer LARCs because of their high sticker price. So the funding allowed them to do that. Yes?
I was just wondering a little bit about why they decided to do this in 2018.
Yeah.
Just a little bit of the context and history about why this initiative happened.
Great question. 2018 is when Virginia went fully blue. So this was a midterm election where they flipped, so they all of a sudden had their state, so the governor was Democrat, and then they also had the House and the Senate were all blue at the same time. So a large number of policies were kind of passed that were more left wing. This ended up getting through as well.
It'll be interesting, what other policies went through, sort of examining, but yeah, cool, thank you.
Yes, absolutely. So that it is a really important point, but what should we expect other things to be changing during this time because of what I just explained? This is also why I'm going to show you effects from just a within Virginia analysis, because if we're worried that there's just a big policy landscape and a lot of stuff is changing also in Virginia relative to other states. We don't want that combination of stuff to be changing birth rates. We want to just focus on that. So I'll show you the effects for just within Virginia as well. Yeah, Mike.
So in this kind of setup, should we be thinking that there's a lot of pent-up demand that's going to be serviceable, right? Funding starts flowing, or are there going to be constraints so that we're thinking that like the IUDs or whoever are going to people who already have pre-existing employment? Like, is it going to be like a big like flood helicopter drop of IUDs, or is it like a flow that starts from
Potentially some of both. So we're gonna talk a lot about whether we think these are just IUDs going to women that we're already going to get them at Title X clinics. And I think we're gonna say a little bit of yes to that we'll see effects on the intensive and the extensive margin. But generally, I'm gonna show you some evidence that we think it is some substitution for people that would have just gone to the Title X clinic. On the other hand, the total number of LARCs in Virginia is gonna increase relative to the US time at all publicly funded. So it's a little bit of both. We think there's some substitution, which I'll show you, but there's not like so much excess demand that these are just people who have been on a wait list or anything like that. Anything else? Okay, so I think a question that, especially if you're just like, I don't really know why these folks are focusing on LARCs in particular, so why did we start with just LARCs at these Virginia clinics? Of course, this is mostly because LARCs are expensive and they're highly effective. So the failure rates are less than 1%, that's the same typical use failure rate as the official failure rate, simply because there's no use of error. The other thing that's nice about LARCs is that they can last really up to 12 years for Paracard, depending on the type and the brand. And again, these are quite expensive. They do require a procedure. You have to have it inserted by a doctor, both for subdermal implants and for the IUD. And so the procedure there is going to cost, this is the sticker price from the price sheet that the Virginia clinics gave us. So for them, it's going to cost about $1,100 for an IUD to be given to someone for free. This is why most clinics weren't offering this, had applied for the funding before.
Yeah. So could you say something, maybe you're going to get to this, about how much of this would be paid for by the program versus Medicaid, women who are Medicaid?
Sure, so it's a good question. I don't have the exact payment for the CAI clinics. I do have it for Title X. And so what I can say on that is that for Title X clinics, about 3/4 of folks that are coming in are getting services paid by Medicaid. They might not pay for the full cost depending on what you receive. So the thing about the CAIs, at least from just talking with Emily and folks there, is that like a lot of the women that are coming in are uninsured. And when you look at the distribution for the demographics of patients, it really is like the lowest income women that are coming in to get this. I'll have to look and see exactly, or ask them what percent they think are on Medicaid. But for the most part, the impression that I've gotten from them is that it's mostly uninsured.
I guess I would have thought that it would have been like not the lowest income, because there is Medicaid expansion in Virginia at this time, right? So, but not up to 250.
That's right. So there's a challenge, and it also leaves us with an asterisk here on lowest income women because they don't verify income reporting. So you could also have maybe somebody coming in who is on their parents' insurance but doesn't want to tell someone that they're on their parents' insurance, or is worried their parents might find out they're getting an IUD, say 24. And in that case, they might come in and say, yeah, whatever, I'm a student, I'm broke. And so they're gonna not verify that, it'll just be 0, and that will be their household income. So yeah, all this to say, I think we could do maybe more on that side, but we haven't really dug into Medicaid population. It's a good question, yeah. Other thoughts, yeah?
Are you gonna be able to see, like, to differentiate, who already have children? Who might be with Medicaid versus not?
Yeah, so we can look at whether or not this is like first birth, second birth, and in that case, we're actually gonna find very similar effects across. I'll talk a little bit about this. To your point as well, I'll also say, even though we're getting there, that the effect is actually larger for higher educated women, which goes against the story of this lower educated group, but, lower income group. But I think I think what I'm going to get to, and what I'm convincing myself slowly over time, is it's actually just like women that are maybe in school or just got off their parents' insurance or for whatever reason, they're using these services, and maybe they would have gone to Title X instead, but they're choosing these because they hear that the LARCs are free. And so we'll talk a little bit about that more, but yeah, it's an interesting, all these subgroup things are more and more and more every day, but there's no effect on like first versus second, which is also different from these other things. Great. So just to round off this slide, I'll mention that to provide a year of oral contraceptives, it's about a quarter of the price. Importantly, you could think, well, but if you're getting the LARC the last 10 years, it's actually going to be cheaper in the long run. So all this is to say, like, we're going to talk a little bit later about what people are switching away from instead of when they go to get a LARC. So that's just something to keep in mind. So let's talk a little bit about these clinics and what was happening. So between 2018 and 2021, these Virginia clinics that received money starting in 2018 were responsible for about 1,000 LARC insertions. It's quite a lot of LARC insertions, even for just the number of clinics that were opening. And starting in 2019, these clinics began to offer other devices as well. So you can see here that trend in LARCs is the one at the top, still going up. But then you also start to see women coming in for the injection, which is a method that lasts for 3 months, and then the birth control pills is the one that's meeting, and by the end of 2021, it's almost the same number of women receiving LARCs as are receiving birth control pills. So folks in Virginia really want me to highlight, look, this isn't just a LARC initiative, this is a broad contraception access initiative where people are able to receive a lot of different devices beyond just LARC. Yes.
What do you mean no method?
Excuse me?
What do you mean by no method?
Yeah, so these are women that might be coming in to say get some sort of screening and they're not taking birth control. Either mostly because they don't want to. These aren't women that are necessarily trying to get pregnant. So in fact, they ask like, are you using something? Are you trying to get pregnant? These are simply people that just don't use any method when they have sex. So exactly what it sounds like. All right, so what data we're going to have to answer this question, we're gonna look at the locations of all of these contraception access initiatives. Many of them are obviously already freestanding buildings, things like Planned Parenthood clinics that are now going to open and up these extra set of services, hire staff, et cetera, to have more LARC insertions and other services offered. We're also gonna be able to have this client level data. This is going to give us information on what's happening at the visits, including demographic characteristics, self-reported income. We have the data service and the clinic visited. So this is really nice because most of the work in this area just doesn't have a lot of information on the clients themselves or what's happening at these visits for the clinics that are opening these sorts of funding initiatives. We're also going to match that with restricted use data from the NCHS. And the state of Virginia has also given us zip code level data. So again, we can look at the within Virginia statistics for birth rates as well. And we're going to use mother's county of residence to do that. To construct birth rates, we're going to use SEER data. This is just county level demographics that we'll have for the number of women, for example, that are age 15 to 44. So we can construct those rates. And then again, our goal here is really to compare the birth rates in counties in Virginia with those in bordering states with also publicly funded clinics. So trying to compare apples to apples as best as possible. We have some other approaches in the paper. If you don't love this comparison group, but I'll show you today just the same specification as well as our within Virginia analysis. So the nice thing for us is that we are looking at an intervention here that had one start time, 2018, where some counties received new services and some didn't. So we're going to do a very simple difference and differences analysis. We're going to just look at this variable of interest here. This is the Contraception Access Initiative variable. So whether you're a county that got a CAI clinic starting in 2018, and then other counties outside of Virginia with clinics that did not receive Virginia clinics.
Can you account at all for like county sides and the difficulty of getting from one county to another? Like, is this different in Virginia than maybe Colorado? Like, the counties could be farther apart and the county effect might be bigger?
Yeah, that's a great question. So we are gonna get at this a little bit. The first way is that we're gonna be thinking about large counties versus, in terms of population, which will be smaller in size, versus not as large counties. So we will be waiting here. That's gonna give us more emphasis on more urban counties just by design. But we also do have a specification where we're looking at areas that it's their first clinic opening. And those are just gonna typically be more rural counties, and we see similar effects there as well. We haven't done much in terms of distance travel, but it is something that we can do think more to data. Because we have, I think, zip code information for everyone that came into the Thank you. Yeah.
The way thing that you mentioned in the slide is women that may demand.
We're just waiting by
Or
the,
just all women,
sorry?
or just all women.
We're doing, well, I should have been more specific here. We're doing childbearing age women, so 15 to 44. Yeah. Great. So what we're going to rely on here with this estimation technique is that, of course, the trends in birth rates for women in these counties that had newly opened CAI clinics should be similar prior to 2018 as those in these other counties outside of Virginia with clinics. Assuming that the initiative hadn't happened, those should have followed a similar trend. And so we're going to provide some support for that visually, but in other ways as well. And we think in general, this is a pretty robust result that I'll show you, but we'll also, as I've already mentioned a couple of times, show you this within Virginia analysis in case you're worried that state level policies are changing at this time, or of course we're overlapping with COVID, Medicaid expansion, all of these other things could be players in the background that we don't account for as well. Okay. So I don't want to spend too long on summary statistics here. The point of me showing you this is just to say our comparison counties and our CAI counties, remember our comparison counties are outside of the state of Virginia, look fairly similar. One thing to note here is actually the CAI counties that we're looking at are slightly less white, and so, and actually have lower unemployment rates. So it's just something to keep in mind here, but really in general, these are going to be fairly similar on levels. Now, I was trained at Texas A&M, and one thing that my committee always told me is like, we need to see the raw data. If you can't see something in the raw data, then doing a bunch of fixed effects is probably not going to give you the causal interpretation you want. And so what I wanted to show you here before we get into all of our lovely event studies is that if you just map raw birth rates in our CAI counties versus the comparison counties, you can see that over time birth rates have trended down. This is not a new finding, but that in general they look to be following a similar pattern downward, with the CAI counties actually dropping even further below that dotted comparison county line prior to the initiative. So this is nothing causal, but is at least suggestive that, look, we're seeing this pattern in the raw birth rates to suggest that the CAI might have played a role in reducing birth rates. So now I'm going to show you the main difference in differences results. And this is kind of the key event study here. So this is effect on just total childbearing, so births to women aged 15 to 44, weighted by the county female population. And so what we're seeing here is that prior to the initiative, you have estimates that are statistically insignificant and fairly stable. And then in 2018, as the initiative starts, you have this kind of null effect as well. We think that this might just be to the lag in childbearing. And then you see this big drop off in childbearing relative to counties outside of Virginia. So the effect here is between about 2 and 3%. And that's going to be mirrored by our formal difference in differences estimates, which again show that even without controls, we have the effect here of about 2.4 percentage points, and then once we add controls, it's about 2.2 percentage points. Yeah, Sarah.
Ignore me if this is coming, but can you help us think about these magnitudes relative to like how many women were actually being treated? Like how big would the implied effect have to be for people who were going?
Yes, I promise you we're doing a lot more of that, but to give you the headline there, it's the foreshadowing, if you will. This is about 250 women per year that we would have expected to have a birth relative to other counties, so it's about 1,000 fewer births over this time period. This is going to be much smaller than other initiatives, which are about double that in size. And then we'll talk about relative to like the number of women who got LARCs, is this big or not? It's on the smaller side of what we were expecting. So I'm gonna show you, like, we think this is due to actually women substituting from pretty highly effective devices already, or women that would have already gotten LARCs. And because this is gonna be driven by older women, and there's no difference, like we talked about before, of whether or not this is women that are having a first birth, again, we think this is actually on the smaller side than what we could expect as compared to other initiatives. Yeah, thank you, Beth.
Could you say something about abortion access in Virginia and how that was changing over time?
Yeah, so we can't do a lot with abortion here, unfortunately. There's just not very good data, so we don't have any like empirical estimates to show you. In general, it's not that abortion access was changing dramatically in the beginning of the CAI. Of course, you still have all the challenges with legislation, and it might affect women in the sense that if you just hear about all of these restrictions being passed, you might be worried, or there just might be less supply available of services. So we actually are abstracting away from that in the sense of this project, but for unintended childbearing, for this particular population, about 50% of these pregnancies will end in abortion. So if you think that that should be actually lower in the political landscape, that it's harder to get an abortion, then we should expect this to be like more biased towards zero. But we can't really talk about it in a convincing way here, so we kind of don't get any data on abortion.
Did Virginia pass any policies specifically?
I have to look. It's a great question. I'll have to look more about that because I don't want to say for sure no. And then, the problem is that these policies are coming left and right. And if anything, I would have expected at the beginning of this time period that an all blue legislature is going to actually pass protections, but I'll have to double check.
Do you know if the teens have the highest proportion of unintended pregnancies, and do you have a guess why it would affect teens?
So yeah, I mean, I have to think more about this. So in general, yes, teens have very high unintended pregnancy rates. On the other hand, like a third of women using contraception have unintended births, so it's like actually quite high for everybody. Why we think that this isn't really impacting teens is if you're looking at who's visiting these CAI clinics, it's actually older women. So it's not surprising to us that then we pick up those effects on births of older women. But I think this is more of a positing, not so much of a, we can nail this down empirically. We think it's because of the fact that teenagers are more likely to use Title X clinics, and so they already have access. Whereas here, this is women who maybe for whatever reason are visiting clinics because they didn't realize they had the ability to go to Title X. Yeah, it's a great question. So yes, do teens have more unintended pregnancies? We worry about that from a social welfare perspective because they impose the largest costs on other people. But yeah, I mean, anything that we say about why we're not getting effects on teens here is mostly speculation and who's going. So this gets to an earlier question of, well, what about places that are more rural? And can we think about what it means for this effect to be driven by more urban counties? So in this third column here, we're kind of just showing you a little bit of a robustness check where we just limit the sample to counties that have large amounts of population, so over 100,000 people. This is more urban areas. And when we look at urban areas, the effect is pretty similar. So again, CAI clinics are opening in urban areas, and that's where the effects are. We don't think that that's very surprising. So here it's about a 2.1% rate. Yes?
So I think that question earlier was do you have a sense of cross-border, people crossing the border to go to these clinics, and is your data on natality, I'm guessing it's from where they live, so
yeah,
partly what could be going on is people could be coming from another state, getting their cars and back to those states, and I think that would generate a smaller than expected effect on
that's right.
if that were happening.
That's right. It would bias us towards zero. We can look at. So you're absolutely right. We just haven't done much with the zip code. We do know the mom's zip code, and I feel like we did this a while back, and it was just not that interesting because most people are just living in the same zip code as the clinic opening. But we could do more with that, and we should be able to say that.
Or even I mean, I don't know where these clinics are located, but you wouldn't expect to find in the middle of the state versus wherever.
That's right, they are. Well, so it's tricky actually. There's there's a map that I won't spend too much time on it, but there are actually quite a bit in the northern part of Virginia, which then it would get to your point exactly. But we can look at that directly, and I think we've just not found anything interesting. But we should do that and really nail it down. So thank you.
I mean, it's kind of cool, just off this, like that you can actually measure the control contamination, because you know
That's
where
right.
people are coming in from. So like, it doesn't have to just be ambiguous, you can actually directly just nail it.
Yeah, we
This is
should.
the-
We should do that, you're right. Yeah, we can. This is why I love doing seminars, and we have the wonderful new text that we can run, absolutely. Great. So this is something I've already alluded to, and we've chatted about a little bit, but just to show you the numbers here, if we separate this out by 15 to 24-year-olds, 25 to 34, and 35 to 44, you actually see a much bigger effect. And on levels for the 25 to 34-year-olds, in terms of percent, it's actually, you know, the oldest age group, the 35 to 44, also has quite a big effect. So you're like, why? These don't seem to be the folks that are really at risk of unintended pregnancy. I'll tell you why we think this is the case, mostly because even just switching from oral contraceptives to a LARC, which is again more expensive, is going to reduce births by quite a bit. So this is a change in a typical use failure rate by about 7 percentage points. Yeah.
But just to make sure I understand, so like you could be 21 and
Yes.
get an IUD
Yes.
and then you'll be living your life for 3 or 4 years, and then at age 25, have a lower birth rate.
Yes.
And so like it could be that this is defined.
They do not like their question.
This is defined at the age of which you has birth rather than the age at which you receive service.
Okay.
Yeah. So who knows? There could be dynamics to play.
There are definitely dynamics to be considered. I think the nice thing for us is here, by kind of looking at this shorter post window, we're not really thinking about like if you get a LARC in 2019, how old are you, what age are you? I mean, you can think about doing cohort effects or something like this instead, but yeah, the point is we'll take it. Yeah, so almost like a compounding effect as the program becomes more successful. I will show you, because of the already high take-up rates for LARCs, I don't think that's so much of a worry here, but yeah, it's a good point. So I don't have a ton of time to show you all of the results that we have in the paper, and you know, I think there are many more ideas that I could do here as well, but let me just emphasize some of the effects that we've talked about already. Importantly, we don't see this significant difference by parity, so this is not the teenagers, this is not women having their first birth. This is actually going to be older women who attend college, so they might be more savvy or just figure out ways that they can get access to free LARCs through these clinics. Importantly, the CAI didn't advertise, so it wasn't like, oh, I'm on a college campus and I see this flyer and now I know to go. It's just simply word of mouth and whether or not you were looking up services and found the CAI as an option for you. I'll also mention that we do see larger effects for counties that didn't have a prior clinic. So it does seem like, to your point of excess demand earlier, Mike, maybe it is just some pent-up demand in more rural areas. And again, this follows the literature that if there's a clinic closer to you, you're going to do the perfect thing. We can also rule out a pretty precise effect in the compositional change of the types of infants that are born. So it doesn't seem, again, like we're reducing low birth weight or kind of unhealthier infants. Again, this is really a group, the group that seems to be most affected by this particular policy is older women that, you know, are maybe potentially higher SES or at least have some education. And then if you're worried that people are just switching from condoms to LARCs, this is often a question that I've gotten, like, do we just worry about risky sexual behavior now because people aren't using condoms? We don't see any increase in STIs. And I'll mention here, because I'm an economist, we've done lots of stuff with functional form and thought about other comparison groups. And this is a pretty robust effect of about 2% that we're going to see across many different specifications. I promised you that we would talk a little bit about our within Virginia analysis. So this is using individual level data from the state of Virginia. And what we're doing here is we're looking at births in CAI versus non-CAI zip codes. And what you see is, like, yes, we have negative effect here is about 1.4 percentage points. Lisa, these other policies might not be playing this big role. And so what I'll say here is we have this other specification, take it or leave it, where we exclude Virginia Beach, which is a military base and was less affected by the CAI, but has a lot of weird stuff going on with birth rates. We pick up a star here. All this to say that if you are thinking, well, 2% seems like not that much, maybe there's something else going on, take this as you will. I think this is suggestive evidence that our effect still holds. But you can also say, yeah, but maybe these other things are really biasing your effects. And so maybe this is really a zero effect, that the CI didn't have as much bite as they would like to think. So you can take that into consideration. I do think this, at least as a negative effect, shows us that maybe the effect is also just within Virginia, and it's not just something about the comparison counties that are driving our. Okay, so let's talk a little bit about the cost, and this gets to Sarah's earlier question of like, what do these magnitudes mean? In particular, I mentioned earlier that this corresponds to about 1,000 births over 4 years that we wouldn't have expected had the CAI not happened. And as I mentioned earlier, we use this cost per birth avoided terminology because other studies have used this, and it's about 3 times higher than what we found from the Colorado Family Planning Initiative. So about $6,000 per birth avoided. And so we want to think about like, what does that mean in terms of policy, and how does this, how do we think about the impact of what other things could be going on to explain this kind of small effect and maybe these large costs. And so this is also getting Mike's earlier question, which is like, why wasn't this as effective as what we saw in the 2009?
Yeah, go ahead. I'm sorry. I thought you were gonna get to this. So why was it so much more pricey? Was it just inflation? I'm like, why 3 times higher?
A lot of LARC insertions, not that many births avoided. So expensive services with very little reduction in unintended births. Whereas for Colorado, it's a big effect on teenagers, and so you see a big drop in births.
Got it.
Yes.
Do you know how long they're keeping them in? Like,
yeah.
Like, if we think about like how often people are going in and out to get the LARCs inserted, and like, do we think about a longer time? If it's 10 years, like, should that be waiting for 10 years to revive it?
Yeah, interesting. We can see removals as part of the diagnosis for the clinic visits. We just don't see that many, so we kind
Or
of
just like more broadly, like how long do people need for?
we can look at that in the Title 10 data because we have more post-period. So with the CAI, it's just so recent that we just don't have, we just don't really see removal. So we could dig into that more on the Title 10 data side. Yeah.
I mean, the other thing that you can think of using from the prior work is whether or not there's any like decay in the treatment effect over time since insertion, and then you use that to scale up your estimates, get the total effect, because you have like the initial years and then there's like a decay function of how many additional pregnancies might have been.
Yeah, we can extrapolate that. So we're just kind of, we have these basically 3 years, but yes, we could think about extrapolating that for see like how many more would we have expected? Yeah, due to this compounding effect that you mentioned. So one of the reasons we think this isn't so effective in Virginia as it was in Colorado is because Virginia take-up of LARC was already quite high. So to give you perspective of like when Virginia chooses to roll out this program, at the beginning of the Colorado Family Planning Initiative, take-up of LARCs, especially among teens, was almost 0, it was less than 5%. At the end of that program, when they called it a massive success, take-up was 20%. Here, if we look at take-up for LARCs in Title 10 clinics in Virginia compared to other places, Virginia in 2018 has already surpassed what Colorado ended at. They're already over 20%. And in particular, the LARC take-up rates in Virginia are 10 percentage points higher than the national average as they're starting to roll out the programs. People are taking up LARCs in Virginia. We don't know why it's so particularly popular there, but people are getting LARCs. They're able to find them. Again, we think this is in large part due to the current policy environment at that time. So again, this is in a world where the ACA contraceptive mandate has gone into effect, mainly for privately insured women. Prior to that mandate, privately insured women wouldn't necessarily be able to get an IUD for free. In August of 2012, that rolled out, so more women were able to get that covered by their insurance. And then in 2019, Virginia also expanded Medicaid. So this is something that, we're keeping in mind as we're running this experiment, because we're thinking that, yes, this is going to be a kind of compounding factor in thinking about women's access to reproductive health care at this time. But these other programs that we're talking about and trying to compare our estimates to, they don't have these things going on at the same time. They don't have this very high LARC take-up, and so this is going to be a really big factor here. Yeah.
Melissa, do you know anybody who's linked the mobilization of women's movement campaigns in response to the Trump presidency to increase take-up of IUD?
So this is interesting. I had a grad student working on this exact question, and couldn't really find much in the way of sales, right? When, especially because Trump kind of announced and then won, and then people were worrying all around. There was a big Fox article saying women just ran out and got IUDs. She didn't see that in the data, but it doesn't mean it didn't happen or there's not other people working on this topic. I just haven't seen very convincing evidence. Okay. And so the last thing that I want to talk a little bit about is is this just because women would have gotten LARCs anyway? The CAA tried, they had all this funding, they wanted women to come and get LARCs, but it's just that they're substitution from other places where they would have gotten them, and now their effective cost is free instead of some marginal amount, so they can simply come and get LARCs. So we can only study, obviously, CAI folks from the time of the CAI initiative, but we do have this data from the Title X or the broader network of publicly funded clinics in Virginia. And so what you see is that this gray line here is mapping out the number of total Title X clients, at Title X clinics in Virginia, and it's falling. This represents a national trend. There were also tax incentives and things that led to fewer Title X client caseload over this time in other areas. But what you do see is this uptick in CAI clients that's following this reduction in Title X clients over this time. And so in general, the total number of clients is falling, and we think there is some substitution from Title X clinics to CAI clinics at this time. In other words, if you call Title X and they say, hey, we just don't have any appointments for LARC access, maybe you could go to this other clinic instead. And so now they know they can go there, get it for free. These are women, again, that would have potentially gotten this device. So that's why we think that this effect is actually quite small. And then, again, this is getting to Sarah's earlier question of well, how big of an effect should we have expected? And there's a lot of ways that you can do this calculation. We just do some back of the envelope stuff to say, look, what if we think about anybody that's attending a CAI clinic and they would have switched from no method to now a LARC, or they would have switched from oral contraceptives, or they would have switched from condoms to oral contraceptives, because that is an option that we have as well. So in taking these kind of numbers that are widely used from this Trussell paper in 2009, we can do a bunch of different calculations to map out all of these possibilities. And so if we take all these possibilities into account and take into account that about half of these pregnancies and abortions, we estimate that the CAI could have led to about 168 to about 1,300 fewer births per year. We get an effect of about 250. So this is definitely on the lower end, implying that we think this is women that are switching for more highly effective contraceptives already, or again, would have already received a LARC somewhere. So this is a lot of numbers that I don't have time to walk through in depth, but we can chat about it more after if you guys would like. So I just want to wrap up here by, again, saying that, look, the CAI funded over 7,000 insertions. These were women that wanted to get IUDs that were now able to get them for free. That helps for women that really want to plan out their fertility decisions. This effect was concentrated among the older age group, among the more educated age group, and we do think that there's some substitution of clients from Title X clinics to CAI clinics. And we think that the reason that this effect is smaller than in other states is really a lot due to this policy environment. And so what we're arguing here is it's not the fact that these initiatives, and if they were rolled out in other states, wouldn't necessarily work to reduce births. It's just that we have to understand that in this current policy environment, it's going to be much more expensive to reduce the amount of births that we saw in Colorado and in other states. And so I just want to, again, leave with this idea of the policy framework that I started with, which is this diminishing returns and this higher cost But I wanna say it's not all bad, because the future is now. We have a lot of options for women now, and even though there's a lot of provisions restricting contraception in various states, this is a product that Costco is now going to sell over-the-counter daily oral contraceptives. And so we should be excited that there's been a lot of innovation and research and development. There's now many new IUDs that did not exist when Colorado started their program initiative. We have Kyla, we have Skylina, there's just like so many options, so it's so exciting. But it means that we don't necessarily need as much funding as we did before, simply because the options exist, that women are more educated on what kind of available things that they can get. So that's something hopeful that we can announce. So thank you all so much for your time.
We have time for questions from the floor. I don't have any in the Zoom at the moment. Yes.
I have two questions, comments. One, I was wondering about how homogeneous you can consider the treatment, given that the distance is homogeneous, and maybe a big factor. And so some people that are far away, in a sense, may be more untreated, right? More
Yes.
similar to people in other states. And so that's one. And the other is when you do policy, you focus on the cost per avoiding. But I was wondering, I think you said that the eligible women have to be before 260 of the federal poverty line.
They have to report an income.
Okay,
That is-
because I was wondering, from a policy point of view, even some of that money that doesn't reduce, let's say, avoidance of birth, may still be money that these people are saving. And these are poor people. Maybe it's a byproduct of the policy that it's not all, higher cost in a sense of, or, makes the higher cost, put the higher cost in a little bit of perspective. This is the substitution that you're finding, well, not the one that you find, because I think that they were also free, but more in general.
Yeah, so in terms of your first question, which is distance, so we do care about distance. We'll do more with the zip code county residents. I will say you're absolutely right in that if a new clinic opens in a county that didn't have a clinic before, the effects are larger. So it does seem that distance matters. This is maybe unsurprising. The reason we don't dig too much into that is just because it's kind of like a result that other people have already showed. So we don't think it's that novel, but we can do more with that for sure. In terms of whether or not we think we should continue these programs simply because it gives more money in the pockets of women that we care about. I mean, the counter argument to this is there are still opportunity costs, and maybe we could just give low-income women cash, and then they can buy whatever birth control they want elsewhere, right? In-kind transfers are always going to be less efficient than just giving people that same money. But if we think that this is just easier politically than offering some other service, then sure, this is going to still get at the population that we care about when this program was being designed. I'm just here to say that it's just not as cost effective as it was 15 years ago, and we have to acknowledge that it's going to take more money to reduce birth at this point.
I wanted to hear a little bit more about the acceptability of LARCs, and in particular IUDs. There's a lot of chatter about the fact that it's painful to have them inserted for certain women, that many facilities won't give you pain meds for it and all this stuff. So there's a lot of social media attention to the kind of acceptability of different methods. And I also was wondering whether you saw differences by race and ethnicity in the acceptability of LARCs versus other formats, right? So are there some groups to whom the extension of LARCs didn't matter, but because there was also the pill option that was a little more acceptable to them, or they had less, suspicion around it? I just wanted to know a little bit more about the within population diversity. I mean, Virginia's a pretty diverse state, has a large number of women who are African American and Hispanic, and I wanted to, just know a little bit more about whether the folks that were taking off the LARCs were also homogenous in terms of some of these other dimensions.
Yes, it would be wonderful if they had asked them, certainly not to put you out, but why did you choose this method? So we don't know a lot about it. I will say, it is pretty striking to us that once they started offering, for example, birth control pills, you see that completely go up. So it's not just the case that women are seeing these clinics as LARC clinics, but rather that they want these other methods. In general, we don't, goes back to the earlier question about teenagers, we don't see like a lot of young people coming to these clinics, and a lot of young people are not getting LARCs as well. So that might lead to your comment about pain and just, acceptability, sure. All those things, whereas in Colorado, the reason that we find big effects on teens, those are the ones that are coming to these types of clinics. So we don't see that here. In terms of race and ethnicity, we just don't see any differential effects, like we tried to pick that apart. You're right about Virginia being like a heterogeneous place in terms of race and ethnicity, and we just don't see that many interesting effects by those.
I think it's worth talking about just because there has been a lot of attention to sort of medical mistrust and choice of method and so forth. And so, and if it's being used for spacing rather than stopping and so forth, there are different dynamics going on.
Yeah, and well, and this is a huge benefit for us being able to work with the nurses that are there. Is I can just ask Janelle, like, hey, do you get the sense that this is
what do you
something people are talking about? Are they asking you about pain? What do you guys do in terms of, is there any kind of localized anesthesia or what options do you guys have? And I think in that regard, I can learn a lot. So thank you. I'll definitely reach out to her now. Yes.
I feel like I see, like, I've read, like, a lot of articles on, like, the internet about how, like, there's these, like, differing trends in, like, sexual behavior now, especially among, like, young people, where it's, like, young people are having a lot less sex than they used to. So I was, like, wondering, like, especially in context, if your findings are, like, smaller, like, how do these sort of, like, trends, like, fit in with your results?
Well, this is important too because we're looking over the COVID period. And we have those 2 COVID years, and that also matters a lot here for people who are just locked in together or can't go and have casual sex partners. But you're right, I've seen all the studies. These aren't cool anymore. They're not doing any of the things. So I don't know how much that is driving this relative to, say, Colorado, where it's just a different time period, and so you have the millennials are way cooler. But yeah, it's an interesting thought. I haven't thought about superimposing those trends by generation, but we can think about that more.
I don't know if when they're collecting the data on like incomes and things like that, do they ask any questions about relationship status? Like if women who are taking LARCs are married or they're more likely to be married?
They don't, unfortunately. So they don't ask about marital status. We do have some information on birth certificates about fathers. We tend not to use it because we think there's just so much selection in who reports a father on the birth certificate. But it's something I could also just get anecdotally from, again, the clinic folks of like, how many women do you assume are coming in here? Because we can look by parity and that at least, it doesn't mean women are married, obviously, but it gives some sense of how their household situation looks differentially, right? So,
women are older when they're getting the LARC, so like that's what the effect is. Is it because like you want a LARC when you're married and you don't want to worry about maybe like condoms or something like that?
I mean, we can do something even just descriptively though, maybe with marital status or father's name on the birth certificate, just to see kind of we pick up anything that's interesting. We haven't done anything. Else?
We're right about at time,
Okay.
so why
Thank
don't
you
I
all.